Hello, everyone. Welcome to this new episode of our Connect podcast. For those of you who still do not know us, we are a newborn association founded by the former Colony Group to foster networking among physiology enthusiasts. Pathophysiology Stories is an idea that developed to rediscover the stories behind how the modern intensive care developed, thanks to the curiosity and passion for understanding the underlying mechanism of diseases. Anyhow, today we will talk a little bit less about history and more about a still very active pathophysiologic discussion. I'm Irene Steinberg, and I'm here today with my colleague Serena Brusatori.
Hello everyone, I am Serena Brusatori and I'm a young anesthetist and intensive care doctor. And today I'm here with you to dive into the fascinating world of acid-base balance. And to guide us through it, we have a true enthusiast of the topic, Professor Frantisek Duska from the 3rd Faculty of Medicine in Prague. Professor Duska has spent years studying and teaching about acid-base and electrolyte balance, combining rigorous research with a real passion for sharing knowledge, and we are glad to have him here with us today. Together, we'll explore how to interpret acid-base equilibrium. Professor Duska, welcome.
Hello, everybody. I'm really glad to be here. And to those who don't know me, thank you for introduction, Serena, a lot. And not only I love the acid base, but I love physiology and physiological thinking as a whole. And so I hope I can be of help today. Thank you for invitation.
So today we are going to deal with a topic that has fascinated me ever since my days in medical school. In my experience, this is one of those subjects that doesn't just capture the attention of those of us working in anesthesia and critical care, but also intrigues colleagues across many different fields in medicine. And that's probably because of how fundamentally important it is from a pathophysiological perspective. But I'm also quite convinced that part of this fascination comes from something else, the aura of mystery that surrounds acid-base balance. Many people see it as overly complex, almost like a nerdy topic full of unusual calculated parameters, difficult diagnostic algorithms, and just a bit too much math to feel practical in everyday clinical work. Well, the goal of this episode is to challenge that perception. I hope we will be able to show you, and I am sure Professor Duska will agree with me, that acid-base balance isn't as complicated as it seems, and most importantly, that it can be applied easily and effectively at the bedside. Therefore, welcome Professor Duska, and thank you for accepting our invitation to be with us today. In your experience as both a clinician and a professor, have you also had the impression that many physicians feel intimidated by acid-base balance? What do you think are the main challenges people encounter when approaching this topic, and how do you think these difficulties can be overcome?
Yeah, thank you, Serena, for this question. It's the same with me, right? I fell in love when I was second year medical students, and when we were first introduced to this fascinating area during our classes of biochemistry at university. And I think a lot of confusion comes from that there are different concepts and really different angles to how to look at the same physiology, right? But despite we look at the same thing, there seems to be 3 different acid-base schools which are in the public discourse, so to say, arguing with each other, and it is not helpful. And I hope during this podcast I will convince you that these 3 acid-base approaches are complementary rather than competing or in contradiction. So I think this is important.
Yeah, for sure. And which are these approaches, and which one is your favorite one?
Yeah. So I like that this podcast has some kind of connection to the history, and really the history here. And I hope I'm allowed to start with that because it's important for understanding. So it all started back in the 50s during the famous polio pandemics, and where they first had young people, children and young people on ventilators, and they needed to understand how much to ventilate them. So Bjorn Ibsen, the anesthetist who started the unit, later published a case when they had a child, put on ventilator and hand ventilating, and he describes that the pH went from 7.0 to 7.6 as they removed all the CO2 from the body. And of course, it had consequences, and it was quite dangerous. And they started to kind of understand the acid-base balance and internal environment as the part of the vitally important homeostasis. And since then, it became fourth vital function, right? But the way how they looked at it was mostly through the eyes of bicarbonate buffer system, simply looking at acid-base homeostasis as the ratio between the bicarbonate concentration and CO2, which was representative of carbonic acid. And that it made a huge progress, and it made the groundings for the classic acid-base approach, like pH as a determinant ratio between bicarbonate and partial pressure of CO2. That's fantastic because that gives us the idea that this bicarbonate changes are called metabolic, as we know it, and the changes in PCO2 were respiratory. So we divided the disorders into two broad families, and also the concept that pH is determined as the ratio between these two, right, gave the mental background for the idea of compensation, meaning that if there is a disorder in one system, like in these kids with respiratory failure, the hypercapnia, then the other system will and should adopt bringing the pH back to normal, meaning kidney retaining bicarbonate. So both sides of the equations were increased, and hence pH went back. That was all nice, right? And this was the classical approach. But even the fathers of it very soon realized that, well, the problem is that, yes, we look at bicarb as the metabolic part and the CO2 as the respiratory part, but these two are not independent on each other, because of course there is a bicarbonate, carbonic acid dissociation equation, meaning that whenever PCO2 changes, bicarbonate must change as well, because this is ruled by chemical equilibrium, right? So they used, and then they used their way how to deal with that. And the way was the concept of base excess. What simply they do, they measured, they wanted to know the metabolic part and separate it from the respiratory one. And their approach was, okay, so we simply bubble the sample through the normalize its PCO2, and then do the titration to see how much acid or base is in excess in this sample. Simply they titrated it back to pH 7.4 and measured the amount of acid or base needed to bring the pH back. And that was the concept of base excess, right? And that was the way how to separate the influences of CO2 on bicarbonate. And that's the background of the classical school. In America, they took in the 60s completely different approach, right? They said, well, that is too complicated, and let's use empirical rules and describe this compensation empirically. So based on series of experiments, the Boston School in America provided a set of empirical rules that dictates what the normal compensation should look like. So that means they said, well, in acute hypercapnia, yes, there is an increase in bicarbonate, but we can empirically describe how much this increase in bicarbonate is. And also, if it lasts longer, we know that the increase will be higher, because that's not the increase driven by change in chemical equilibria in bicarbonate dissociation, but it's driven by the kidneys retaining bicarbonate in the body. And they took this approach by empirical equations, and it started so-called transatlantic debate, where papers and journals are filled with fierce debate which approach is better, right? And I genuinely think it's a wrong question, because as I said in the beginning, these are two different approaches to the same physiology, and both have its advantages and disadvantages, but also both share the same thing. They interpret acid-base balance as a status of bicarbonate system. And it is working well for a single disorder with or without compensation. But the problem is that it is saying exactly nowhere where this disorder comes from. What is the reason of it? And obviously, we know that, for example, metabolic acidosis can have a lot of causes, but looking at bicarbonate buffer alone gives us no hints whatsoever about what is the cause of that acidosis. And that is where the ions, electroneutrality, and Stewart approach is needed, right? Even before Stewart, in 1977, Emmett came with the concept of anion gap, right? He first realized that electroneutrality is important, and if we look at the major ions in the plasma, like sodium and chloride, they determine anionic window, and that would help to assess the cause of metabolic acidosis, in this case, the most common acute disorder in critically ill patients. So they came and said, okay, so whenever bicarbonate is low, that means for us that the patient has metabolic acidosis. So we've diagnosed metabolic acidosis. And now we want to know what is the cause of it. And it was before the time that lactate could be easily measured on a blood gas machine. So the utmost importance was to detect an unmeasured anion. And they did it by simply subtracting chloride and bicarbonate from sodium concentration, right? And if that gap was high, they said, okay, there must be some anion circulating in the blood, right? And they call it HAGMA, high anion gap metabolic acidosis. And once this was diagnosed, then the second step was to identify that ion, right? Is it lactate? Is it ketones? Is it something that stems from renal failure, like elevated phosphate or sulfate, or is it something that patient has taken inadvertently, or is it a poison? So that are these questions. If the bicarbonate was low, right, and the anion gap, meaning sodium minus chloride minus bicarbonate, was normal, then that meant that the problem must be in the chloride side, and they call it NAGMA, or hyperchloridemic acidosis. And then the question was why the chloride is so high. Is it lost by kidneys, or in renal tubular acidosis, or has the patient received a lot of normal saline, or other causes of that condition? So that was kind of in the 70s the first introduction of the electroneutrality that helped, in combination with looking at the bicarbonate buffer, to diagnose acid-base disorder. And coming back to your original question, so we are here looking at bicarbonate buffer and perhaps calculating anion gap, and that is as far as we got in the medical school, and that is how we diagnose acid-base, and that is super well working for a clear-cut single disorder, which was the most common admission in those years to ICU. In an ICU, there are patients who are terribly sick, but usually young, with a single disorder, be it an asthma attack with super high super low PCO2, be it DKA with the high anion gap metabolic acidosis, or be it a patient with sepsis and lactic acidosis. So that worked very well. But you can see from it that in case there is more than one disorder that goes against each others, that it's very difficult to diagnose using either Boston rules or classical approaches. And here comes my favorite concept, and that is Stewartian. Because Stewart published his book in the 80s about acid base, he took it from completely different angle. He understood that pH and bicarbonate are dependent variables. They are determined by other variables, and Stewartian acid-base diagnostics is based on determining the determinants of acid-base status rather than looking at the final results. And that is the beauty, and that is the logic that we need in order to understand complex diseases. So if I have to answer what is my favorite approach, my favorite approach is based on Stewartian logic, but not in 6 equations. The problem is that Stewart came with his approach by using very complicated mathematics, and his eye-opening ideas were therefore wrapped up in absolutely incredibly complicated mathematics, and that is why Stewart has that nerdy or geeky reputation. But I don't think it's justified. I think Stewart can be made simple.
That's very, very interesting. Thank you, Professor Duska, for this very interesting wrap-up of what happened in the last centuries in acid-base. And yeah, I am quite interested in the Stewart approach. I mean, I get it is quite complicated, but what it is about? I mean, how does it work specifically?
Yeah, so the Stewart logic is that, let's start with that, because his original concept was that he treats bicarbonate as a dependent variable. And he simply says that bicarbonate and pH are determined by 3 things, 3 determinants that are independent on each other. First is strong ion difference. strong ion difference is, we can easily simplify it to the difference between sodium and chloride when clinically approaching patients. But in Stewartian equations, it's simply the difference between all ions in plasma that are fully dissociated, whatever the condition. So on the cationic side, we've got a few. We've got sodium, which is dominant. Then we've got potassium and magnesium and calcium, and eventually some superminor concentration of other strong ions. If the patient is taking lithium, then lithium is among those strong cations too. On anionic side, it's very simple because we only have normally one strong ions in significant concentration, and that's chloride. And the first determinant of this acid-base status is strong ion difference. And whenever strong ion difference increases, it means that the bicarbonate concentration will also increase. So increase in strong ion difference is an alkalinizing influence, and a decrease in strong ion difference is acidifying. To use a simple example, if you give your patients 2 liters of normal saline, which has very high chloride concentration, then you decrease strong ion difference in patients' plasma, and that is why you make them acidotic, right? So that's the first determinant, the SID. The second determinant is the total concentration of weak acids. Normally, these are represented by albumin and phosphate, and simply they bring some degree of negative charges on the surface of these complex molecules. And these negative charges then appear in patients' plasma. And simply the negative charge on these weak acids is subtracted from the strong ion difference to determine the concentration of bicarbonate. And that's conceptually also important. You can then imagine why, if you have a hypoalbuminemic patient, then low albumin is alkalinizing influence, simply because it occupies the negative charges on albumin occupy less anionic space within that strong ion difference, and hence bicarbonate has to increase, and that is alkalinizing. So that's the second determinant, right? And the third determinant, as it is in classical approach, is PCO2. So if you know strong ion difference, if you know a TOT, and if you know PCO2, you can calculate the rest and determine acid-base status of the patient. But as I said in the beginning, it was usually done by a set of complicated 6 equations. And on the first superficial glance, it did not seem to be very helpful in clinical practice. However, in year 2000, Jim Figge, together with Vladimir Fensel and Antonin Jabor and Kazda, my compatriots, published a landmark paper in the Blue Journal. And they said, guys, look at it again. This concept can be made clinically useful. And they demonstrated on their real cases from ICU that Stewart concept could be eye-opening. That paper, the first author is Vladimir Fensel. It still could be found, it's open access, and I really recommend everyone to read it, and especially look at their case 29, which was a lady who came in with an acid base that looks like on surface as a respiratory alkalosis. But if you look at the determinants, sodium chloride difference and her low albumin, then you realize that this lady has very high concentration of unmeasured anion circulating in her blood, and she was found to have a ketosis, and that case is then nicknamed diabetic ketoalkalosis, and it inspired Paul Elbers to writing his famous acid-base textbook. And it's really nice demonstration just on one case how important it is to look at the determinants rather than into the final results. But still, this Stewart approach, despite these innovations, was sort of detached from clinical practice. But that changed in 2004 when Australian guys, mostly David Story, came up with an approach which since is called base excess partitioning, right? So he realized that simply clinicians are used to looking at base excess as the final marker of metabolic disorder, okay? And they keep doing it, right? So there's no way this is gonna easily be changed. So he took it from there and said, well, why don't we just look at the base excess and look at the Stewartian determinants to kind of dissect this base excess into the components that would then be related to the causes of disorders. So he came up with a simple, practical approach of base excess partitioning. And the way how he recommended doing it is as follows. He said, look first at sodium chloride difference, which is a surrogate for SID, right? And compare it with normal value. Normal value has changed over time, and but let's say it's 35, should be determined locally, but let's say sodium chloride difference normally 35. And whenever it decreases, each millimole of decrease of this sodium chloride difference from 35 must cause an acidosis with the same reflection on standard base excess, okay? So, for example, if the strong ion difference or sodium chloride difference is 25 instead of 35, that means that there is 10 millimoles per liter less anionic space for bicarbonate, and it must also drop by 10, and therefore the base excess should be minus 10. So that allows us to predict how the base excess should be based on strong ion difference or based on sodium chloride difference. Okay, so that was the first step. Then the second step of base excess partitioning is to look at the albumin, right? Albumin has got a 3 millimoles of negative charges per 10 grams per liter. So yeah, of course it changes slightly with the pH, but it's not so important at this stage. So you can determine how much of the anionic space within the strong ion difference is eaten up by albumin. So he also, using the same logic, he said, okay, so if the albumin is low, then each 10 grams per liter drop of albumin must be accompanied by increase of base excess by 3, okay? Simply because that's the more anionic space that must be filled with bicarbonate. So that was his second step, looking at albumin and determining base excess derived from that, okay? And in the third step, he recommended looking at the real base excess that is printed on the acid-base strip. And now was the beautiful part, and he said, okay, so we predicted some base excess from sodium chloride difference and some base excess from albumin. And if we put these two together, it should equal the base excess that we see, okay? And if the base excess on the blood gas strip was more negative than the predicted one, that means that there is a circulating anion. Rarely, if it was more positive, then there is a circulating cation, but that's the rare occurrence. And since the circulating anion was detected, then it was identified the same way like when we were dissecting anion gap. And that was really, really good approach. This base excess partitioning is nice because it looks at the causes of acid-base disorders and their individual components rather than at the final status. So if there is two metabolic disorders like the hyperchlorhydrinic acidosis and alkalosis with low albumin or whatever, canceling each out, you will be able to see it because you look at the determinants, not at the final status. And that was the beauty of base excess partitioning.
So you mean even if the base excess is normal, because you have two different disorders going in different directions, then with this new method, you can say, well, pH is fine in general, but the situation is not normal because I have two different disorders. I have an acidosis and an alkalosis going on together.
Yeah, perfectly. So if you have a patient, I'm showing my famous case that it's with a guy who has a failing liver with, lactate of 20 and 13 millimoles of other acid circulating in his blood. But due to vomiting and chronic liver disease, his chloride is so low that it gives him so much acidosis that despite 30 millimoles of circulating anions, his pH is completely normal. And that is exactly where this base excess partitioning pays off. But it has one big caveat or bias or disadvantage. And that is that it only works when pH is very close to normal. And that is the thing to be explained just a little bit, right? This caveat is that you need to be very careful in patient with extreme pH is that Stuart looks at the plasma anions, and whenever sodium chloride difference changes, it is assumed that this is an acid-base disorder. But plasma does not live isolated in the whole body system. And whenever there is a pH change, right, the intracellular buffers, mostly hemoglobin in the red blood cells, try to help and buffer some of the acidic load. And that buffering is transferred to plasma compartment by changing the sodium and chloride concentration. And that means that whenever pH drops, for example, during respiratory acidosis, that is automatically accompanied by a degree of widening of strong ion difference. But this time, it's not disorder, it's not wrong. It's a physiological compensation. Then simply the erythrocytes are taking up the chloride, widening the strong ion difference in plasma and helping the system to buffer. But luckily, you have very smart guys in Italy. And one of them, who I'm now super lucky to work with, realized that this shift is numerically predictable. And he did, an immense amount, and his team, and with Thomas Langer and Professor Gattinoni, immense work on predicting how much this increase in strong ion difference is, and realized that it is predictable, and for each drop of pH by 0.1, the strong ion difference widens by 1.5 millimoles. And that means that whenever you are interpreting or doing base excess partitioning, you can just be aware of the change and mentally correct for it. And that means that now base excess partitioning is universally available for all acid-base situations, and that's great. And that is the Stuart Light approach, which is my final recommended approach that I really, really encourage people to use at the bedside, because over the years, we realized that this is very good compromise between going into the depth in combined mixed acid-base disorders and mathematical simplicity that you don't need any calculators and it can all be done on Friday night in emergency room by mental arithmetics. Of course, it would lead to, there is millions of other simplified electroneutrality-based approaches, corrected or calibrated anion gap, corrected chloride, delta-delta approach, and many, many others. And there is absolutely nothing wrong with them, and they will lead to the same results, same outcomes. The only thing is that I personally find them more complex mathematically and less intuitive and less stepwise. So that's why I incline to promote a little bit this Stuart Light. So Stuart Light, if I recapitulate, we divide it into the five steps. So in the first step, of course, you want to look at whether the patient is in extremis. So you still look at the CO2 pH and bicarb, and at this stage you can assess the ratio between CO2 and bicarb. And I encourage everyone who can do it to use Boston rules for that, because this is exactly where Boston rules pay off, and these were designed for it. I give a practical example, right? If you see a patient in profound acidosis, let's say DKA, right? They come to call you to see a patient in emergency room, high blood glucose and super low pH, presumed DKA. Then looking at the PCO2 is very important, because we know that metabolic acidosis is compensated by hyperventilation. So we know that the PCO2 should be lower, below the normal range, right? But the Boston rule is telling you how low it should be. And for metabolic acidosis, you use bicarbonate multiplied by 1.5 and plus 8, it will tell you how low in millimeters of mercury CO2 should be. And if it's any higher, that means that your patient is probably not coping. They are not compensating anymore. So you need to keep very close eye on them, admit them to intensive care, and they may need respiratory support unless you are able to quickly deal with the acidosis. On the other hand, if the PCO2 is lower, that means that the patient would have superimposed respiratory alkalosis, and that requires further investigation. So you need to ask yourself, well, if the patient is young and female, isn't she pregnant? That would explain it. Is there anything, is it just anxiety or pain, or is it something else on board? Like, you know, salicylate overdose would typically cause that pattern, and so on. So this is your first step, that you look at how extreme is the change, whether you see a clear-cut disorder and whether it's compensated or not. Sometimes by using pattern recognition, you don't need anything else and you just have a diagnosis. However, I recommend you to go and do another step, which would complete and finish the Stewart light. So the next step is look at the sodium chloride difference, right? And compare it with 35. And that will tell you about the SID disorder. SID disorder means that usually we call it hyperchlorhydremic acidosis or hypochlorhydremic alkalosis in classical approach, but that would tell you about this component. Knowing about this is important because, for example, you will choose the appropriate fluid for the patient. If the sodium chloride difference is too high, and if there is a high SID or hypochlorhydremic alkalosis, you may safely use normal saline. On the other hand, if the SID, sodium chloride difference, is already low, you would rather choose balanced fluids, or even, if it's more extreme, reach after bicarbonate infusion, which is for very low SID and absolutely appropriate fluid. So that's the SID step. The third step is looking at albumin. Low albumin would lead to high base excess, is an alkalinizing influence. It's not that important on its own, but it just complements the picture and allows you to the fourth step, which is look at the base excess you predicted from sodium chloride difference, the base excess you predicted from albumin, and compare them with the base excess you see on the blood gas machine, and that would allow you to diagnose the unmeasured anion. And then in the last step, you simply summarize the disorders that you detected, and you must use your clinical and physiological thinking to put them in order. What's the primary disease? What's the compensation? What's the chronic disease that the patient has? Of course, no kind of way of acid-base analysis would give you that information. You need to use your clinical thinking and the patient's story to determine this. But that is about how I practice Stewart light. Once you master it, you may take it one single step ahead, and that is to correct your sodium chloride benchmark, the number, according to the pH. If the pH is low, you expect sodium chloride to be a bit wider. I said a bit, but I mean you add 1.5 millimoles of this sodium chloride difference for each drop of 0.1 pH unit. The other way around for alkalosis as well. And by doing so, you've got reasonably precise, and we've shown it, and it's now published in a British Journal of Anesthesiology. We used a large database of over 5,000 blood gases and calculated it compared with the full Stewartian strong ion gap calculation, and there is a minimum bias, so it's very safe to use it in clinical practice.
Thank you. It was really great to start from the polio pandemics and come to the last discoveries of the last year. So it was really a great talk. Thank you for sharing with us your knowledge. And I really hope that now acid-base will be fascinating, not only because it is a mystery, but also because we got something more about it and can apply it at the bedside every day in clinical practice.
Yeah, if I can just pose a question coming from the less, I would say less skilled on acid base. So I think a lot of our listeners are now thinking, okay, that's a lot of information. So do you have, I mean, this all putting in line of all the things that you need to remember is really useful. But do you have any other tricks or things that you can suggest to our listener to easily apply this to the bedside?
Yeah, I think if I'm honest, also this concept is really teasing. So I hope that I draw attention to it, but I don't think listening to one podcast will lead you that you can come to your unit and do it straight away. If you do, that's absolutely fine. But I think you need to do a little bit more preparation. So the next opportunity we will be discussing it and showing it is at a smart meeting, because I understand that most of your listeners are Italian. So if you are going to smart meeting, we will have the acid-base course there, and it's 1 day. If you want to take it really thoroughly, then I recommend you to visit the schoolacidbase.eu webpage, which is a webpage of our summer school of acid base, who was founded by me and Professor Gattinoni back in 2019. And since then, we meet every year in September in Prague for 4 days, right? And Serena is there among the faculty, and Thomas Langer and Lorenzo Giosa and Paul Elbers, Manu Melbrain, and other figures from acid base. And there is frontal lectures as well as the cases. So we spent the whole afternoon at the table in small groups solving real cases, and that's a great opportunity to master your skills in it, and you come back home doing it. And I really recommend you to try this. And I think for September there is still few places left, so if you can come over, that would be great. If you prefer self-study, then the Stuart Light is summarized. It's been published and it's available open access in Intensive Care Medicine Journal. And I recommend you to open this supplementary appendix when you see the Stuart Light approach applied on the real cases and solved by step. So there are 3 cases, so you can study it and then go back to the unit and look at your patients, right? And try to apply it. And by doing so, you learn it. If you are not sure whether you are correct or not, and if you lack an instructor on your unit, then you can always type the numbers of your case into the full Stewartian calculator that is available at acidbase.org webpage run by Paul Albers. So so you can analyze your case, write your diagnosis down, and then type it in, do a full formal diagnosis, and got your feedback. So that's the self-learning way. And whilst mentioning acidbase.org webpage, you can buy a Stewartian textbook that was, me, Paul Albers, and John Kellum are the editors. And it starts with brilliant Stewart text, from which you learned inside out the Stavertian approach. And I think this book is really, really good investment of time. You can, if you have 2 long weekends to spare, then the book is for you. So that would be my approach. The good news is that once you start practicing it, right, this step-by-step sort of mental arithmetics, your brain will start doing it for you. And the Stuart Light turn into your brain into pattern recognition. So you stop doing calculation, you just look at the blood gas and albumin, and you see what's wrong with your patient, and it's relatively good news. It will make you better doctors. So please do invest in studying acid base. It's worth it, definitely.
Thank you, Professor Duska, and thank you for all these resources. They are really, really precious. So I want to thank also Serena for being my co-host today. And I want to take advantage of your attention for just a few minutes because as Professor Duska was mentioning, the SMART meeting is coming up in Milano and Connect will be there. We will have 2 full days of session. So if you plan to attend the meeting, you're really welcome to come and look at what we're doing. We will really be glad to meet up and explain if you have any question. And also, if you're interested in this podcast, you can find the 3 previous episodes online on Spotify and on YouTube. And you can follow the Connect activities on our social media, Instagram and Facebook and LinkedIn. So again, thank you so much for listening, and thank you, Professor Duska and Serena Brusatori.
Thank you for having me, really. I hope I did not make it more complicated. Thank you so much.
Thank you, everyone, for listening, and see you next time.